Hi, my name is Dr. Steve Auerbach. This presentation will be on why are U.S. prescription drug prices so high and what we can do to control them. I'd like to thank my colleagues, Doctors Rotolo, Goriaco, and Karani, as well as Professor Peter Arno and Dr. Peter Smith. So, quick overview of what is single payer. Single payer, single public agency organizes the healthcare financing. There's a single insurance pool. Everybody pays in through progressive taxation. Nobody is excluded, and everything is comprehensively covered: medical, mental, dental, long-term care, hearing, and vision. No deductibles, no point of service costs. And this includes prescription drugs, and it would cover everybody in the United States automatically, cradle to grave. So again, just to be clear, it's the financing, not the delivery. It's the national health insurance, progressively funded. It provides security. Everybody always has it, regardless of any changes in their job or life circumstances. It increases freedom. All the doctors, hospitals, and pharmacies take it. There's no prescribed networks, greater freedom of choice for patients, no point of service costs. It's not the same as the national health system. That's not what we would be proposing, not like the UK or DoD or the VA system. But the delivery of care services continues to be provided by the same mix of mostly private entities. So within that, let's talk about U.S. prescription drug prices and costs. So U.S. drug prices are increasing way above the inflation rate. This shows the year-by-year brand name drug prices for the top 260 drug products compared to the general inflation rate in the orange. And basically, there's a price increase of somewhere around 5% twice a year. And cumulatively, this was resulting in brand name drugs increasing in price by over 300%, and even generics increasing by over 700%. Again, U.S. drug prices are rising far faster than inflation. Looking just at the 49 most common top-selling brands between 2012 and 2017, 78% of them had an increase in their insurer and out-of-pocket costs by more than 50%. 44% more than doubled in price. The U.S. spends more on drugs, more than twice the OECD average. For any given drug, anywhere from 1.5 to 12 times the price. And remember, these are all transnational companies, the same drugs by the same companies being sold across the world, but the United States pays more, much more, than other Western industrialized capitalist democracies. Again, looking at different drugs across different countries, we pay far more for these drugs. The ratio of GDP per capita compared to the ratio of the average drug price in the US, again, just shows how much more we are paying. And again, another way to look at it, the average outpatient drug spending for an older adult who had been hospitalized with heart failure and comorbidity of diabetes, how much are they spending on outpatient drugs? And I think this is a good, useful measure because it's a common situation amongst an older Medicare population who have some chronic, severe diseases and need to be on daily medications. These are common comorbid conditions that folks would have. And again, we have here an international comparison where for persons in the United States are having to spend far more than persons in other countries for comparable care. And again, it's not that the other countries are not prescribing the drugs, it's that per drug, we're paying far more. So just to take an example, here's the cost of insulin in other countries. And I would suggest that one of these prices is not like the other. Another common example, a combination medication for persons who have asthma or COPD. And again, looking at other countries we might consider comparable to us, and boom, one of these countries is really not like the other. But what about research? Whenever we want to control the cost of drugs, the pharma industry lobbyists will say, oh, but you're going to hurt research. Well, let's look at the multiple reasons why that's not true. First of all, drug companies' actual cost structure, only 13% is devoted to a broadly defined research and development. Much of the rest of it is marketing and administration, as well as, of course, profit making. Notice an 18% profit after taxes. In fact, the drug companies are recently spent more in buybacks and dividends than they did in research and development. This is according to their own reporting over the last 5 years through 2021. Indeed, pharmaceutical revenue from U.S. sales exceeds the revenue from the rest of the world combined. You look at the 20 top selling drugs in the United States, the U.S. sales accounted for 101 billion, and the entire rest of the world 57 billion. Again, pharma is making more money in the United States than all other countries combined. 11 out of the 13 drug companies selling those top 20 drugs made more in the U.S. than sales in the rest of the world combined. And just by comparison, this includes the EU and UK, which has a larger population than the United States, and also the entire rest of the additional rest of the world. So by population, far more in the other countries, and yet the United States is double the amount spending. Now you might say, well, the drug companies need that. Well, in fact, the drug companies are getting excess prices from the United States. This shows the return on revenue for drug companies compared to the Fortune 500 median. We certainly want the drug companies to make a profit. Got nothing against that. We just want them to make the same profit that other Fortune 500 companies are comfortable with, not triple that on a return on revenue basis. So essentially what we see here is that the U.S. is subsidizing excess profits by the drug manufacturing companies compared to the normal profits that they make elsewhere. Again, every other rich capitalist democracy negotiates the prices that they pay. They pay a fair, profitable price rather than the excess price gouging that their drug companies are able to excise from the United States. And in fact, public funds pay for most real innovation and research. Pharma claims that they spent $83 billion in research and development in 2019, but the Congressional Budget Office suggests that over half of that is mandated clinical trials, and a lot of it is incremental extensions. In other words, just new doses or new delivery systems or combinations, all of pre-existing, already approved standalone drugs. This is a way that the drug companies manage, one of the ways that drug companies extend patent protections, and they're calling that research, even though it's actually the same old drugs. We know that, in fact, the National Institutes of Health is the major source of basic biomedical research that leads to new drugs. And that, of course, is taxpayer money. Even pharma acknowledges that at the very least, 1 out of every $3 spent on drug research comes from the American taxpayers. And that's with some generous measurements on their part in their favor. This doesn't even include the fact that a lot of those dollars are tax advantaged in terms of flowing to research foundations, academic medical centers, where they are not paying taxes and then get to also have write-offs. And it doesn't include the fact that there's research that's paid for by other countries' governments. The United Kingdom and Germany and Taiwan and Japan and France all have their equivalents of our NIH. Through which research occurs. In fact, the NIH contributed to every one of the 210 new drugs approved by the FDA in recent years. And I have to say, it wasn't always this bad. Things got worse with the Bayh-Dole Act in 1980, but in fact, there's been 60 years of changes in patent law favoring corporations, and in particular big pharma, over the tax-paying citizens. So infamously, though, the Bayh-Dole Act really had a huge effect on the way the pharmaceutical industry works. Before that, um, publicly funded research funded by taxpayer money, let's say through the NIH, if it resulted in a patent, then the public could share in that patent right. The NIH, on behalf of the taxpayer, having paid for the research, could share in the patent rights. After Bayh-Dole, that was forbidden. Only the folks who did the research and with the NIH grant and the corporations that they contracted with for further development could share in the patent. It also made it in general harder to regulate the patents and pricing. The Bayh-Dole Act, they're supposed to cite the public funding on patent applications, but they don't always do so. The statute says that the drugs must be made available to the public on reasonable terms, and we would argue that reasonable terms means reasonable prices. The statute does allow for some the government to do so-called march-in and grant the license to other manufacturers if reasonable terms are not met. Of course, all of these things were routine before Bayh-Dole. So the idea that this march-in is some wonderful new thing, actually it's the other way around. It's sort of the exception that's now been built into the law. And in fact, whenever such petitions have been filed, they've been ignored or rejected. Classic case of patent abuse is Humira. So Humira is used to treat many inflammatory immune conditions such as arthritis, psoriasis, Crohn's disease. And in fact, it's become in recent years the #1 best-selling drug in the world with $18 billion in global sales. As an example of patent abuse, there have been 247 different patent applications over the years, all for the same drug. The goal here by the company has been to delay any competition, delay any release of real generics independently, and to be able to create a monopoly to allow them to charge whatever the heck they want, at least in the United States. And of course, the drug companies have lots and lots of lobbyists and spend lots and lots of money on lobbying. But wait, it gets worse. So in addition to the drug manufacturers and the retail pharmacists, in recent years, there has been added a new middleman, so-called pharmacy benefit managers. Now, this was sold to us on the idea that, oh gosh, putting somebody in between the insurance company, the retail pharmacy, and the patients to negotiate prices will somehow reduce costs to the insurance companies and government and the patients. But they are for profit. They're actually allowed to terminate the contracts without cause at any time. So essentially, they're guaranteed profit and have no risk. It creates limited networks. And at the end of the day, it's just adding another for-profit middleman. And clearly that never saves money. This is how PBMs work. And you can just see it's just an insane kaleidoscope of interactions, each one of which has to, since they're for-profit companies, has to extract a profit. In fact, it gets worse because they're not actually independent. So what we've seen with monopolization, vertical integration, is creation of inherent conflict of interest and self-dealing. So you have an insurance company like Aetna, which is the same company as a retail pharmacy, CVS, which is the same company as a pharmacy benefit manager, Caremark. And this is true also with United owning Optum, Humana, Cigna. So there's no savings when the insurer, the benefit manager, and the pharmacy are all the same company. It just is a case of each division becoming an additional profit extracting center. Furthermore, it allows them to play various accounting games with payments and charges and overhead shifting between those divisions and resulting in additional monopoly power to raise prices. So what's the impact on stakeholders? Well, for patients, high drug prices obviously hurt patients. Cost-related medication non-adherence is far higher in the United States than it is in the comparable countries because our out-of-pocket costs are much higher. We see here that in the United States, there's a clear correlation between pre-Medicare age persons who don't fill a prescription because of cost. Those who have no insurance are the folks most likely to not fill a prescription, and if they have good insurance with no gaps, they're less likely to. And we know that as you begin to add quote unquote skin in the game and have a higher amount of out-of-pocket payments that the persons have to pay, even though, let's say in this case, they're in Medicare, there is a drop in the number of prescriptions filled. Basically, what they found was with this experiment in the real world is that an increase in the cost sharing of $10.40 per drug. So the person had to, let's say, have a copay of $10.40 more than they did before, resulted in a 22% drop in total drug consumption. These are of the prescription drugs that were prescribed for Medicare enrollees who had health conditions. And it resulted in a almost 33% increase in the monthly mortality rates. So skin in the game kills. Copays kill. And we have found other studies where this is true, in addition to the one I just cited, true for patients with COPD in high deductible plans, non-adherence in persons living with diabetes, and similarly in young cancer survivors taking the medications that they needed to take after cancer treatment. There's an impact on hospitals. It's largely hidden from patients, but in fact, there has been over a 38% increase in the hospital drug spending between 2013 and 2015, and over 90% of hospitals say that higher drug costs are causing a strain on their budgets. And again, the growth in inpatient drug spending far outpacing inflation and actually outpacing the hospital reimbursement from the insurance companies, again, driving up costs for the overall system. And frankly, monopoly power is a huge part of this. 50% increase in a drug called Daraprim after it was bought up by one company. IV acetaminophen, 2.5 increase after being bought out by another company, Mallinckrodt, and Isopril, 500% increase after its acquisition. So as companies are bought up and increasing monopoly power to leverage increased prices, there's also been other gaming of patents under the guise of quote unquote reform, with branded versions of unapproved older drugs and creating de facto monopolies on what should be competitive generics. For doctors and other prescribers, we have an increasing frustration due to inconsistent formulary restrictions, cost-sharing copays and deductibles. Every doctor out there can tell you about horror stories about patients having so-called cost-related non-adherence, not filling the prescription at all, or splitting pills in half and only taking half the dose, skipping alternate days, and things like that. Now, the AMA said there was a 92% of physicians saying that prior authorizations had a negative impact on patient clinical outcomes. I don't know who the other 8% might be. All I can think of is maybe they're coroners. But every practicing physician and other prescribers like nurse practitioners have horror stories. And let's not forget the pharmacists themselves. The pharmacists themselves are the front line for handling and explaining claims and cost concerns around prescription drugs. They're the ones who have to explain to the patients about the copays and deductibles, the prior authorizations, or that such and such is not even covered. Patients are obviously frustrated, and it's the frontline pharmacy workers who bear the brunt of that. Furthermore, we've seen the monopolizing chain pharmacies, putting all the mom and pop pharmacies out of business, and then turn around and having pharmacists as employees being treated poorly and overworked and burned out. So what do we need to do? Well, the proposal under single payer would be for so-called monopsony purchasing power. This is where the buyer, rather than the seller, has monopoly power and leverage to negotiate better prices. So as the single payer, the government entity would be able to have better consolidated power to negotiate with the drug companies for lower prices. And again, all we're asking is for the same thing as what every other developed capitalist democracy does around the world, which is negotiate the prices. Every other country does this. The drug companies make a fair profit in those other countries. They're simply price gouging in the United States for excess profiteering. It would also mean under single payer plans as they've been proposed, no copays, deductibles on medications, removing point of service costs, removing that skin in the game so that people feel free to actually fill their prescriptions and take them as prescribed. And frankly, a transparent medication formulary so everybody's on the same page with what's going on. Now, until we achieve single payer, there are many things we can do. A version of let the government negotiate would be let Medicare negotiate. So when Part D was first implemented, there was a huge fight over this, and the good guys lost. We ought to let Medicare and all public programs negotiate prices. The VA already does this. Department of Defense and TRICARE already do this. Medicare does this to some extent, and there's a carve-out program within that, 340B program. It's the same as the private insurance companies and those PBMs ostensibly do. And frankly, again, it's the same as what every other wealthy capitalist democracy does. Let Medicare negotiate prices. Now, whenever we talk about those negotiations of prices, we do need to be careful between very different things that sometimes get conflated, sometimes disingenuously, deliberately so. So a price cap is not the same as a cost cap, is not the same as a copay cap, and is not the same as an out-of-pocket cap. For example, a copay cap only applies if you have insurance. So for the uninsured, a copay cap does you no good. A cost cap might cap the amount that it costs the patient, but it might be behind the scenes that the taxpayer is paying the drug company a certain amount behind the scenes as opposed to an actual price cap. So again, we need to keep those fine points in mind as we look at what's being proposed. There are some additional reforms we would call for in terms of reforming the Bayh-Dole Act to allow the public to share in patent rights, stopping the abuse of patents with various gaming around lookalikes and combos and extended release and generic captures, march-in rights and mandatory generic manufacture, and just in general, more of a public role in research and development, manufacturing to assure not only a fair price, but also beneficial for stable manufacturing prices so we don't have shortages and deliberately or de facto deliberately led manufacturing-led drug shortages. And also, very importantly, public to pay for effectiveness and comparative effectiveness research. Under the current system of the FDA mandated trials, paid for and run by the self-interested drug companies, we don't get those comparative trials, and we do get, in some cases, misleading research regarding effectiveness. And now I'm going to stop here and take questions. Thank you very much.